So I'm talking on the pulmonary hypertension tool, and I want to give a bit of an update. We have a varied audience here, so the first half is a little bit of a quick review of what it is and what the sort of framework is. And then the second half, I want it to be an area where we can generate a little bit more discussion and debate, and I want to sort of garner the thoughts from the group on some of the definitions and criteria that we've come up with. I am presenting this with Dr. Brunner, and it's on behalf of the steering committee, which is myself, Dr. Brunner, Jason Weatherall, Ali Kapasi, Nathan Hambley, Sanjay Mehta, John Granton, and Steve Provencher. And so what I want to do is go over, as I said in the first half, a little bit about what the PAH tool is, who's participating, how it's being structured and managed, and some of the logistics of how we're storing data, or what the options are to store data. And then from there, a little bit about the data that's being collected and some of the definitions that we're using. So first of all, for those that aren't familiar with this, what is a PAH tool? It's a PAH-specific database that was developed in Portugal. Abilio Reis is the pulmonary hypertension physician in Portugal, along with Marino Pomberio, who is the IT person who, in partnership with Actelion, had developed this program probably about 6 or 7 years ago, I think. It's a web-based system, and it's currently in use in multiple countries. This is just a diagram showing the countries that are currently using the PAH tool, with the asterisks indicating a couple of the countries, particularly a couple of countries that are in the process right now of implementing. So what is the PAH tool? Is it a registry? Is it a research database? Is it a clinical tool? Is it something for practice oversight? So for example, from a national perspective, is it a way of trying to dictate, regulate, or oversee how clinics are practicing? Or is it a electronic medical record? Well, it's not in its current form an EMR. It's not meant to be, although Abilio has talked about creating that functionality down the road. But that aside, really for these other criteria, it can be whatever we want it to be. And when I say we, I mean we as either a national group or as an individual clinic want to make of the tool. And I'll talk a little bit more about sort of what our philosophy is as I go along. The PAH tool, when we initially kind of conceived the idea of revitalizing a national registry for pulmonary hypertension, we discussed a number of criteria that were necessary for whatever system we brought forward. And the PAH tool, to the best of our ability, meets all of the basic criteria that we were looking for in a database. Ease of use and being web-based, tailored to pulmonary hypertension, so in some way disease-specific, cost-efficient, meeting the necessary standards for security and confidentiality, but also maintaining the balance between control of data and the ability to share data. And then also have both a clinical and a research utility, or the potential functionality for both. So what are the objectives of the PAH registry? First and foremost, really, they're to characterize and monitor the pulmonary hypertension populations in Canada. Right now, I think for many centers, if you asked how many patients do you have from different categories of pulmonary hypertension, how many patients do you have on therapy, what is your mortality rate, what is your functional class distribution, most of us, without doing a fair amount of work, will have a difficulty answering those questions with any degree of sort of accuracy or on a regular basis. And also from that, to measure and improve the quality of care of patients with pulmonary hypertension. And the bullet points I have below that aren't in bold are some of the different ways that we can go about doing that. So we can track basic demographics, diagnosis, treatments. We could track clinical outcomes like hospitalization, lung transplantation, death. We could investigate the prognostic parameters or other imaging modalities or clinical parameters to look at association with outcome. We could look at the effects of different parameters on hospital admissions, quality of life, demographics associated with outcomes. We can look at risk tools, whether it's trying to apply other risk tools to our population or comparing our population to other populations, and to facilitate contact for future research. And that's both in individual centers across Canada and potentially internationally. One of the advantages is that there are many centers across the world that are using this. And so there is the potential for international collaboration. And I think comparison to see whether or not the Canadian population is comparable to other populations in the world, whether our treatment standards are achieving the same goals, and whether we're where we should be as far as care for our population. This is where we are with the centers in Canada. In Vancouver, we have been entering data since January of 2017. Thank you. In Calgary, they've been entering data now since the spring, and Hamilton also around the same time. And then right now in the process of ethics approval is Edmonton, London, Quebec City, and Montreal, and Toronto is probably next up on the block once we have a few things sorted out and going with some of the other centers. You can see one of the things, you can see that for Vancouver, there's ethics approval has an NA, and the reason is because we have a slightly different model in Vancouver, which I'll explain afterwards, which makes the PAH tool not a separate database, but part of the hospital record. And so it's not considered in the same way that you don't need a consent to have a chart on a patient in a clinic. You don't need consent to have them in our database. Although that is something we're discussing further as to if we need to do that in other ways down the road. So in Vancouver, our data is stored inside our hospital inside our hospital servers, so inside the firewall of the hospital, which means that all of the security checks and balances that exist for all other patient programs in the hospital encompasses our PAH tool. So we can have all unique identifiers, we can have patients' names and birth dates and PHN numbers and healthcare numbers, and without any concern. And we have a web, and although we still have the ability to access the program through web-based, it has to be within the VGH firewall to do that. It works very well for us. It gives us a lot of utility and a lot of flexibility for clinical tools. The problem is that it's a lot of work to set up, and it's not an approach that's going to be feasible in all centers across Canada. And so as we went through this process, and part of Vancouver starting up was to go through some of this process to learn and to try to improve the process and find better ways of doing things. And so as we went through our process, we looked at what other options would be. So other centers could potentially have in a similar to us, have it on their local hospital servers. There could be local university servers. Portugal offers a service where you can basically buy memory and they store the information, but that comes with concerns about exporting data outside of the country. There are private servers which also come with concerns about privacy. And then one of the other ideas that we discussed was having one Canadian center within a university provide a host server, which is the way many registries in Canada operate. And all centers could then access some portion of that host server. And so what that prompted us to do was to set up a server at UBC that can be used by any site in Canada. And basically, we can have it run one PAH tool, although I think in the partitions it can run slightly different programs if that's what we decide. Ultimately, what we're hoping is that everybody in Canada uses the same program. And when I say same program, what I mean is the PAH tool is highly modifiable to needs. So depending on what a program's clinical need is or research need is for the database or the registry, the group in Portugal will modify the program. So you can modify what variables are seen, whether variables are optional or mandatory, whether there is field limits on parameters and that sort of thing. on the UBC server, any center that participates has their own partition, and nobody can access that partition except the center, and potentially, if we want to establish it, one national oversight manager. And so it allows centers to have somewhere to house their data without having to set up a server themselves, but still maintain their control and ownership of their piece of that information. We have a general IT group that supports basically the interface between UBC and between the programmers. And will also then facilitate going the other way between the UBC servers and the individual sites. So setting up usernames, setting up passwords, troubleshooting problems with access and that sort of thing. And so they're meant to, they've been supporting us in Vancouver, but they're meant to support all the sites in Canada. All right. Now, in the think tank last year in 2017, I wasn't there, but one of the discussions was, when we discussed the PAH tool, was one of the major obstacles to implementation is the complexity and the time and energy required to set it up. Everybody has good intentions, but everybody also has too many things on their plates, and one emergency pushes out another, and then you start facing an entire field or area that you really know nothing about, and you have to start from scratch and try to figure out how to put an ethics application together, how to look at the program. And so one of the things that was discussed was why not have one person that coordinates for everybody and helps sort of shepherds every center through the process, tries to take care of all of these centralized issues in one place. The problem is that we all already have full-time jobs. And so what we discussed was hiring a national project manager. And this would, as I said, provide all sites with assistance. And it would also try to create uniform SOPs, operating procedures, forms, and that sort of thing that all centers could use, basically to make it as easy as possible for individual sites to get started. And so if Lena, who introduced herself earlier when we first went on, has joined us in July of this year, and has been working on just exactly these things over the last couple months and helping the sites that are in the process of ethics right now getting up and running. And so that sort of speaks to the government structure for the PAH tool. There are centralized responsibilities, as I said, having running the servers, keeping the program up to date, standardizing manuals and worksheets and SOPs, keeping training logs and best practice. But one of the things that, and again, this gets to what I was speaking about earlier, the philosophy of the PAH tool. In its current form, it's not meant to be a method of oversight of the centers in Canada. So we're not trying to use the PAH tool to dictate how centers practice. It's supposed to be a database or a registry of how people are practicing, how people are cared for, and not, this is not for example, being produced by the Canadian Thoracic Society or the CCS. And so every site's going to be responsible for, that participates, maintaining their own data and entering the data as they feel is appropriate. So for example, we do have, I'll talk about our data set, we do have parameters that we believe we've collectively agreed on as a group that we believe are important that everybody collects. But we're not trying to say that people have to collect these parameters. What we're saying is that we want them if you can collect them, and if you do collect them, record them. Funding, so the license for all of Canada has been paid for by Actelion J&J. The cost of UBC servers and IT support is covered by funding, some from the clinic and some from Actelion as well. And then we have, for Lena, the project manager for the first year has been provided kindly by Actelion and J&J. And we're looking at funding going forward from, I know there's been some discussions with where did Sanjay go? He stepped out for a minute. So there's been discussions with PHA, and also we've been talking to pharma for ongoing support of the tool. And right now the primary goal of the project manager is to get the program, get the centers up and running. That role will evolve over time as more centers come online, and it's going to be a role more to maintain the program, and whether or not we start looking at national efforts for projects, so whether coordinating data extraction and collaboration, as well as and ethics submissions and that sort of thing, as well as data auditing. The idea was to try to minimize cost to individual sites, to try to take down any barriers for centers to become involved. So the core national data set. So when we first conceived the idea of a registry or a database in Canada, one of the philosophies that and principles that we tried to come forward with was the idea that if we have a database that has 250 variables and everybody's collecting 50 variables, but there are different 50 variables at every center, then the fidelity of the data and the utility of that data for any kind of epidemiologic analysis becomes very low, and the ability to draw very confident conclusions from that diminishes. And so the idea was that we'd rather collect a few data points with very high fidelity than have lots of data points with very low fidelity. And so initially, this is what we initially came up with, was 5 or 6 variables for first visit and for follow-up. The idea being that it should be very easy for everybody to collect them. We've had a little bit of an evolution in our thinking over time, and our concern was that just keeping 5 variables, it might be nice to only have 5 with high fidelity, but you can't have so few that the data doesn't really inform. And so we tried to find some balance between having more data points than was in the initial minimal data set, but not so much that it becomes onerous to enter and to maintain. And this is what we've come up with. So this is what we've established in the last 3 or 4 months over as the core data set. And we're open to debate or criticism on these points. But the first is a demographics, and these are things that would essentially be entered the first time a patient comes, but wouldn't necessarily be entered in follow-up visits. The only one potentially that might change would be, like for example, weight and potentially postal code. But we have age, sex, ethnicity, height, weight, postal code, whether they're incident or prevalent patients or undergoing screening, and what their WHO classification is. Postal code will be a bit of a sticky one, and so it's going to depend a little bit on local IRBs, whether we collect full postal codes, or even if it can collect first 3 digits of postal code, it would give us some information on geographic distribution. It also has information about socioeconomic status and that as well. The clinical parameters, again, the ones that we tried to collect were a combination of ones that were clinically, what we felt would be clinically useful, but also ones that were within existing risk tools, so that we could potentially apply some of these tools to our population or compare them. This is with syncope, heart rate, blood pressure, the clinical signs of right heart failure and progression of symptoms. Some of these come from, again, from the REVEAL, particularly the REVEAL and the ECS guideline for risk stratification. Hospitalization, WHO functional class, outcomes, PH medications, and we did discuss including a quality of life questionnaire. And the sense from our group was that if we're going to collect a quality of life questionnaire, this is a good time to all kind of try to universally agree on one and all collect the same one rather than everybody collecting a different one. And we had chosen the emphasis 10 for a number of reasons, particularly ease of use and availability. Investigation, 6-minute walk distance, the basic right heart catheterization parameters, as well as, again, the basic echo parameters, DLCO if available, VQ, and then BNP, pro-BNP, and creatinine. And we realized that not every center is going to be able to collect all these parameters. For example, some areas don't have access to BNP, or some people may not be collecting them every time. For example, you're not going to have a right heart catheterization every time somebody visits. The idea is that if the information is available, it should be recorded. And so, for example, if the patient has 2 or 3 visits with echoes and then a right heart cath, when the right heart cath is done, it should be entered into the database. So it's not necessarily that this information is supposed to be collected every single visit. This is just a graphic illustration of those same data points. And just so you get a sense of where these come from, I'm sure most of you are probably familiar with the REVEAL registry. They have a number of different parameters in the risk score, and we attempted to have all the parameters that are in the REVEAL registry as part of the core data set, as well as what is in the risk assessment table for the ECS. The one exception is the cardiopulmonary exercise testing, because we just felt that there's so few centers that are doing that regularly in Canada that it wasn't going to be part of our regular core data set. And then this was, for those of you that were at the PAH World Symposium, this was the simplified risk stratification tool that was proposed, which was neither the ECS or the REVEAL or really Compara or French registry. It was an amalgam, a group of experts' opinion on the best amalgamation of those variables. And so we also wanted to try to ensure that what we had was incorporated into that, not necessarily because this is what new practice is, but because it would allow us to compare some of these different risk stratification tools. I want a few minutes to talk about classification and definition, because I would like to garner some feedback, but quickly before I do, are there any comments or concerns with what we have proposed here for data points? No? Okay. As I said, I think this is a balance between not collecting too much information, but collecting enough that we have some flexibility in what we want to do with the information once we have it. And again, this isn't meant to not just be an individual, or not just meant to be a research tool to compare the risk stratification tools, but it can also be a clinical tool in a real sense to be able to calculate risk scores for patients as they come through the door, which is where we're working towards in our clinic. So classifications, definitions. So one of the things is even if you have one center with 3 or 4 doctors, or you have 4 centers across Canada, each with 3 or 4 doctors, if you're going to start trying to put the information together, then you have to make sure you all are speaking the same language. And it might seem simple to say they're category 1 pulmonary arterial hypertension. Everybody knows what category 1 pulmonary arterial hypertension is. But when you start to nail down some of the details, you realize that there are some subtle finer points that do need to be agreed upon in our definitions. And so for category 1 pulmonary arterial hypertension, as many people know, the current definition is greater than or equal to 25 for a mean pulmonary artery pressure. And people may also know that in the last World Symposium, there was discussion about moving that cut point down to 20. For people that don't know the argument, the idea being that 20 is closer to what is believed to be the upper limit of normal for the population mean, and 25 having been more of a historical cut point for pulmonary hypertension. So one of the discussions among our group was that it would be interesting to collect that group between 20 and 25 for 2 reasons. One of them is if the guidelines change with the next iteration, then we would sort of be ahead of the game. The other is that if the guidelines don't change, potentially that group would be an interesting. It would be interesting to have maintained data on that population and to be able to evaluate them. There's 2 ways that we could do that. One way is to change our cut point for diagnosing PAH to 20 now. The other, and so we collect all those people. And for example, if it stayed at 25 and you want to publish based on 25, you could remove those people from your data set when you went to analyze. The other way to do it is to maintain it at 25, maintain the cut point at 25, and just mandate that as an added point that all centers enter anybody who's 20 or above. And so those patients are entered, but not necessarily entered as a diagnosis of pulmonary arterial hypertension. Really, either way works, but from a practical standpoint, it's easier on a large-scale population perspective or large-scale center perspective to just have a lower cut point and have everybody enter from there. The problem is that may not align with what people are exactly doing in their clinics. And now this would have to come with a PVR definition greater than 3 Wood units, which would make for a relatively small number of people that this would be irrelevant for. Now, one of the other things about the PAH tool is you can have any category 1 PAH and other categories of PAH. So you can be entered in the PAH tool as category 1 and category 3, but you can't be indicated as IPAH and anything else, because the whole idea is IPAH is a diagnosis of exclusion. And so the idea is that if you have a little bit of heart disease or a little bit of lung disease, then you're entered as IPAH, and your lung disease and heart disease are listed as comorbidities rather than other classifications of pulmonary hypertension. What do people think about having 20 as a cut point as their mean pulmonary artery pressure in the database? Any thoughts or ideas? No? I guess maybe the better question to ask is anyone have any strong objections to that concept? Or they think that it's a wrong way to go? No? It was John's idea. That's like Calgary had already planned to do this when they were entering this, so they'd already started entering patients with 20 or over.
But are they considered IPH?
We see, no. Yeah, so not considered, well, no.
You want
That's
to
right.
enter those patients, but that doesn't mean they have a diagnosis of...
That's right. So the other way you could do it is we could keep it at 25 and ask that all centers enter patients that are 20 or above with a PVR greater than 3.
Yeah.
And we call it a screening patient.
Put somebody
Right.
with a diagnosis that is not a real diagnosis.
Right.
Right?
Now,
I mean, you would put somebody with a diagnosis that is not per se as being official.
I agree, but I think what we want to do is make sure that if we were interested in that, if we said, oh, and by the way, if you could do the 20 to 25, we might miss that opportunity because people may forget to include those. Whereas if we make the cutoff 20, at least we can include them and study them as a group. But then equally, we can. It doesn't mean that when we publish, look at it, we can't set the break off at 25. So you can recalibrate it for analysis. So, and we would never say to a patient necessarily, you know, you've got this thing, we think it's a problem, but no, you can't treat it. No, but.
Categorized as screening, that means that, yeah, you enter that patient for
Yeah.
a certain reason, but they don't have a diagnosis
Right.
written somewhere in the registry.
Yeah, but I think the conversation you have with the patient is different than entering them into a registry.
Yep.
So, yeah, so I think we just wanted to make sure that we caught them, and then we can cut it
No, I think it's
whatever way
important
we want, yeah.
Get them, but it's how do you classify them within the registry
Yeah.
until it's,
Sure,
the definition
Yeah.
has changed.
yeah, but we can cut the registry according to a
Yes.
different cutoff,
Yeah,
yeah.
I mean, like I said, you could play that either way because you could enter them as 20, and if you were doing if you're looking at your population and you wanted to say present a pie chart of your PAHs, you could just create a cut point rule that says anybody with a PAP less than 25 gets cut out of the database, or you can go the other way, and you can enter them as screening, then include or not include as you see fit. I think in a pure sense, I think it would be better to have a 25 and have that group as one that you could include or not include. But I think from potentially from, and I would have to say I was opposed to this idea initially, but you know, as I thought about it, I thought that, you know, maybe from a larger implementation standpoint, it's easier to be inclusive and then cut later than try to add in people that may or may not have been captured with fidelity.
I'm just wondering, because to enter them into your database, you're gonna get consent, correct, from the patients?
For most centers, yes. For our center, no, yeah.
So how are you gonna explain it to the families that are 20, at 20, that we're gonna put you in this pulmonary hypertension database, but you don't really have it, they're gonna go and start Googling it, and then we panic. So you're gonna have to deal with some of that education, like how are you gonna monitor?
Well-
that we're gonna monitor you closely and have you back every so many months, or you're symptomatic but you don't quite fit there, so exactly how are you gonna keep that patient from being very anxious about
Yeah.
the potential diagnosis?
Yeah, you bring up a good question. So first of all, in Vancouver, it's a moot point because we enter everybody. And so it doesn't matter whether you're screening, whether you've had a formal diagnosis or not. Anybody who comes through the clinic is entered in the database. And so there's no discussion about you being entered because you have this diagnosis. But you know, I think you're right. For individual centers that are only entering patients that are diagnosed with PAH, then, and you have to gain consent, then you probably would have to have some discussion about the fact that, you know, you have a pressure greater than 20. But I would argue, maybe I'm wrong on this, but I would argue that most patients that have mean PAPs over 20, if they've got PVRs over 3, they're probably, and they're category 1, they're probably being considered for treatment just like others.
Yes,
don't-
true,
yeah.
but so now, do you put them on treatment? Do you, like, how
So whether patients go on treatment or don't go on treatment, again, that this, I think is a completely separate discussion. Again, the database isn't necessarily mandating how you treat them. So even if we call them 20 in the database and you call them PAH, that doesn't necessarily dictate that any requirements to treat or not to treat, I think.
If you start treatment, would you not give them the diagnosis of pulmonary hypertension? Like, how are you gonna get approval for even the medication without giving them a diagnosis? Because we in Alberta have to put them in a program, like you
Yeah.
have to check them off.
Yeah.
So now you have to have a diagnosis, so now when you enter it into the database, you're gonna enter them as having pulmonary hypertension. So that's all I'm just
So,
wondering.
yeah, no, I get what you, let me just make sure I understand your question correctly. So if you weren't using the database, you're saying you wouldn't treat them unless they're over 25? Is that-
Well, if they're symptomatic, then I guess.
Then
that's-
maybe,
Yeah.
yeah.
Or you're gonna do a right heart cath, and then you're gonna go from there,
Yeah,
right?
yeah.
And symptoms, I guess. And so then I guess you get some gray into that database a little bit too, right?
Yeah, because it shouldn't change, like if it was someone who you might, because they're symptomatic, treat them clinically, then that's what you do, and regardless of whether or not you have the database. And if it's someone who you wouldn't treat clinically, then you don't, regardless of whether you have the the database doesn't change whether you do, you don't. So the discussion is still with the patient about, whether, what to do with somebody in the 20 to 25 range in the PAH. Yeah.
John?
Yeah.
It's a really good question. And it's very few
Yeah.
number of people, I think, that fall in that 2025. But, to me, it's like saying you have a precancerous lesion. We're not quite sure what we should do with it. Should we just watch it, see what happens? And that's probably the answer. Should we cut it out or whatever? I don't know. I don't think we know, but I think you need to follow those people, particularly somebody who has a high-risk condition that has a 22. By the time you get to 22 and you're a young person, that's a large loss of the cross-sectional area of your pulmonary circulation at rest. So I don't know what to do with those, but I think we need to start paying attention to it. At the very least, you need to follow those patients very closely. I think we all have examples of people who might have been dismissed or we referred back to be followed by somebody else and we wish we hadn't. They come back and then they're class 3 and their PA pressures are much higher than that. So I think it's actually a service to patients to kind of say they're in that unknown area, as much anxiety as it causes, but they're all engaged, smart people, and they probably Googled it already and hear that conversation. They're going to come back to you and say, well, I'm abnormal, but I'm not really abnormal. What are you going to do? And this might reassure them. I don't know.
Lisa?
Yeah, I was actually, that was going to be my point. I think that's exactly why you should put them in your database, right? Because it's just answering another research question. It's a question we don't have an answer to right now, which is now we have the ability, and if we do this right up front, to create data on a large cohort of patients in this early range disease. Any given clinic probably has a very small number of these patients, but if we all do this across the country, we might actually get some power to be able to see what is the natural history of somebody with a mean PA pressure between 20 and 25. I actually think it's very powerful to do this. I think it's a semantic question about whether you call them screening or not. I don't think that's important. I think the really important piece is exactly what you said. We don't actually know what the natural history is, but let's collect it and find out.
And I guess at the end of the day too, if you're a center that really doesn't believe this, then you just don't enter them unless they're 25. And you just make sure that everybody knows that when you're collecting information.
I was just gonna add that, a lot of centers now have my charts where patients can actually access their own results and their own clinic notes that are being written about them, so I think it's they should have it, so, I think you would probably be having that discussion with them anyways, whether they were in the database or not, so I think it's, that's, for me, that would be,
Our patients are seeing their information
They
now
see their
anyway,
own
in their
charts
my
as well.
charts,
Oh, yeah, yeah.
you know what I mean, like,
Yep.
we're moving.
Oh, sorry.
Yeah, yeah. Sorry.
there you go.
Yeah, what Amy was trying to say, our patients are moving, our electronic medical record is moving to an ability for them to see their own information on my chart. So, as Amy said, they'll be able to see this information and start questioning things anyway, so.
Any other thoughts or comments on that? So it, yes.
Just going to say, we're sort of new in this process, and so we're one of the centers that is consenting patients. And one of the issues we're struggling with is how to have the consent process sort of operationalized in clinic flow. But it's a good thing, like it's good to have those discussions, and
Yeah.
it takes a little more time than we thought it might, just even to consent patients. But it sounds like sort of a process of right heart cath happening and then structuring time in clinic flow to consent and discuss database. Certainly what we found is sort of a good time to do it.
Yeah, yeah. Yes.
John, comment and question, if I may. The comment is, first of all, awesome. So great to see it moving. We in Ottawa absolutely want to be part of it. We've discussed it internally, and as soon as our coordinator can get in touch with our folks, we would love it. But the comment is, as you move sites on and get ethics approval, and move people into the database prospectively, it's going to take a long time to get data that's of large enough value and use for everybody. One thing I would pose to consider is if there are resources, to look at resources that could backload the data, right? So if resource is not an issue, you may want to consider implanting resources at individual sites where data can be retrospectively added. And then all of a sudden you will not have to wait 3 years to have 500 or 1,000 patients, but you can have retrospective data. Obviously not as statistically rigorous as prospectively collected data, but at least it's data in that you can use. I guess maybe another comment then. My other comment is on the line of resources, we have to make sure very carefully that it's as hands-off from industry as possible. We talked about that last year, but I think it's really important that we need industry partners to help us to fund this, but we have to really be quite clear about it, which is my third point on governance. You've put a lot of work into the governance, but a couple of questions with the governance, because I think it has to be really well defined. One is the issue with industry, right? The relationship with industry. And the other aspect about governance, I wonder if you've given any thought yet, is to governance around, you talked a little bit about ownership of data, but about publication, about people querying, wanting to use the database that may not be users or users of the database, so external sources. Who decides, that sort of process. I think as sites come on, I think there should be given a little bit of thought to that. Maybe you already have, subcommittees that can be present to evaluate the research question, approve the data, a priori decide on authorship, et cetera, et cetera.
Yeah, no, those are all very good points, and all points that we are either working through or struggling with at the current time. I'll start from the latest and see if I can remember to answer each one as we go along, but if I don't, let me know. So first of all, with regards to the question of access and research and that sort of thing, so that is the next phase that we're working on, and that's something that Lena's going to be working on in the next while as we start getting some of the sites settled in. But in addition to the steering committee, we are definitely going to have a dedicate what we envision, but what hasn't yet come to fruition, partially by necessity and partially by need, is to have a smaller group or another committee that is charged with oversight of research clinical trials. So for example, if somebody had a research idea that they wanted to propose for the PAH tool, they would put that forward to the research community, who would vet it for scientific merit and content. And then if they gave it their stamp of approval, then it would essentially ease the way for other sites to just say, yes, I'm going to participate. No, I'm not. Yes, I'll provide my data. No, I won't. And then have some sort of centralized way of extracting the data in a anonymized fashion, and potentially also putting in the ethics submissions. So you're right. We do need structure and governance around that for sure, and that's going to be the next step as we kind of move into a point where we have analyzable data. But at this point, we haven't had any, so we've just put that as the next kind of stage of things, but it is definitely something we have to work on. And as far as the back entering, it is something that we had talked about. The concern has just been the amount of effort that it would require, and B, if we're going to do that, we thought it would probably be better to do it within the context of a specific goal. So, for example, if if somebody wanted to do a research project on a certain outcome, in relation to certain populations, then they could do a chart review for whatever centers they chose, or somebody could, and back enter that data. But to university back enter a clinic, it's possible, and it's something we can definitely think about. But I don't think right now we have the resources to do it for everybody. And so if if an individual site was interested, then maybe we could look at some ways of finding costs to do that. But then, like you said, you get a retrospective population, which is fine. Those are, I think, an interesting population society too, and provide a lot of information. But just by way of the power, so we've been up and running for a year and I guess 3/4. We have 900 something patients in the database already, and over 1,800 clinic visits. So the information, 2 years goes by pretty quick. The information accumulates fairly rapidly, and hopefully, as the other centers come on, that number, that'll be an exponential increase. So I think it's definitely something to think about. But I think we have to, if we're going to invest that much energy, then we have to do it with specific intent. But and then obviously, yeah, you're absolutely right that we have to maintain clear boundaries with the various sponsors that we look at. And Actelion thus far has been very generous in providing us with support without without indicating or trying to dictate how the process has evolved, or how we've put it together and what kind of parameters we're collecting and that sort of thing. So we've been very fortunate that way. But I certainly agree that going forward, we just need to have a clear relationship sort of statement, and a clear idea of how we're going to acknowledge that when the time comes.
Mostly in the sense of peer review, right, when you publish.
Yeah.
One of I think the great values of this, and as a Canadian flavor, we will be able to get data on outcomes in Canada as it relates to the Canadian treatment landscape, right?
Yeah.
And all of the issues of the access to therapy, et cetera, et cetera. I mean, that's very powerful data. When we go to publish that, peer review will want to know what the relationship is there
Yeah.
with industry. So I think we have to be really careful and have clear statements and guidance around that, so
Absolutely.
that our data is acceptable for good publication.
Yeah, I completely agree. Yeah. Any other comments or questions at this point? Yes.
Sorry to interrupt. I'm really going to encourage everybody, please use the mics, because we're not getting anything.
Oh.
Because I'll be interested in this afterwards.
Is that working? Just a question from the pediatric standpoint. Having not been part of the community earlier until 2014-15, when this sounds like this has started to evolve, what role did you think the pediatric population had in participating in this, particularly the transition patients?
Yeah, well, no, I mean, again, there's no reason why, as far as I know, and I'm not a pediatrician, but as far as I know, there's no reason why this tool in its current form could not be directly applicable to a pediatric population. And so it's, it would be, I think, primarily a consequence of interest. And so if there are pediatric sites that are interested in participating, then by all means talk to us, and we can look at what can be done and what options there are. Is that sort of what you were asking, or?
Yeah, no, I've actually spoke with Jason a little bit about it. I just wondered the value in terms of the Canadian community.
Oh.
Do they want pediatric data? Do you want those older teenagers in there? Does that help in terms of where this database is going?
Well, I mean, we haven't put a ton of thought into it at this point, so it's an interesting thing to explore, and I think it would definitely be an interesting population to have and to see them moving through a longer time span from the pediatric population to the adult. We'd have to, I think that's a fantastic idea if the centers are interested in doing that. And I think there's a limited number of centers that have dedicated pediatric programs that would be able to participate. So it's something that we could certainly work on. Yeah, I think this you highlight a good point, which is probably a bit of the disconnect sometimes we have between the pediatric and the adult clinics, and maybe not as strong a relationship or a bond with them as we should. And this might be one way of sort of building that up a bit. So, yeah. Any other comments? So one of the things about the mean PAP, just to go back to that for a second, the mean PAP of 20, is the question then becomes, is that the definition of PH, or is that the definition of PAH? So then do we move category 4 to a mean pulmonary pressure also of 20? And do we move category 2 do we move category 3? And so this is something that we do have to discuss. So currently, the concept was that category 4 would be, again, capturing the intermediate group with a mean pulmonary pressure greater than 20, PVR greater than 3, and a wedge less than or equal to 15. And then with the caveat that there is angiographic evidence of thrombotic disease with anticoagulation. And so again, the question becomes, does category 2 include a mean pulmonary pressure greater than 25, or do we also move that to 20? And be interested in people's thoughts on that. In this case, the definition is fairly straightforward with evidence of left-side heart disease. And for category 3, again, the same question. We've included some parameters to allow for, to provide some framework for interstitial lung disease being an FEV1 less than 60% with a ratio less than 0.7, or an FVC less than 0.7, and or evidence of CT findings that would be consistent with lung disease. Now, obviously, if you look at this definition we have here, it wouldn't necessarily encompass, for example, an OSA patient. So we have to have some qualifiers for the other less common subcategories within category 3, but as a initial framework for the bulk, that's what we're kind of looking at. And so what do people think if we decide for category 1 that we change it to 20? Do we change it to 20 for all, or do we leave that specifically for our treatable populations? Now, the other thing I want to highlight is that the PAH tool in its inception is intended to collect category 1 and category 4. So it may be that many centers won't even be collecting. This is an irrelevant comment because category 2s and 3s won't be collected by other centers. In our center in Vancouver, we collect all patients, and so we want to gain information about these populations as well. And I suspect that many centers will, but some centers may choose just to do the minimal data set, which would be category 1 and category 4. So.
At our center, we talked about the CTEPH patients and CTED and had sort of been interested in collecting all CTED and kind of arbitrarily had said if we'd gone to the point of a right heart cath and they meet the chronic angiographic part, they would collect them sort of on an exploratory basis. But interested to hear if other centers are going to want to capture that group too.
So some way of capturing patients who have no PH but have chronic thromboembolic disease. Yeah, that's an interesting. I mean, we all know those patients. We all have them in our clinic. But when we were going through our definitions, I don't really know if we kind of mentally worked our way through that variable.
Yeah, I agree with you, Doug. I think it's a very interesting group of patients to study and to collect data on. I mean, and I'm not sure the cutoff of 20 is, I will probably collect all those who have a right heart cath personally. I mean, sometimes you see, a young patient with a mean pulmonary artery pressure of 18 on clear extensive disease. And then, a number of times you follow them and see what happens. But I think it would probably better to capture all of them rather than just that kind of category. And I think the new definition is really going to be applied to PH, like category, like the group 1, not the 4. I think that was the plan at the conference. So I think it's important to capture the data. I'm not sure what they did for PAH is going to apply for CTEPH, but certainly the CTED category needs to be studied. It's an opportunity.
Yeah, it's a good point. And then, it's just if I think about then when it starts to get difficult is how much chronic thromboembolic disease you have to have before you're called to see it. If you have somebody who has a single subsegmental lesion and no PH and is asymptomatic, then do you enter that person? Do you not enter that point? Are you going to have a certain disease volume before you be called a CTED versus just somebody who has a little old PE somewhere that just stuck around?
The whole concept of post-PE syndrome, I think, that you capture basically. But it's an interesting group to investigate.
Yeah, I think we struggled out just in our group, and we sort of thought that if the clinician was worried enough to do a right heart cath, that might be the cutoff, but it was pretty arbitrary.
So you have to, you could say something along, you have to have been cath to get into the group or something. Yeah. That's a reasonable.
Yeah, so we're, of course, collecting everybody, but I think we should maintain consistency amongst the groups, and the working groups in the NICE meeting did all talk about lowering the mean PA pressure threshold down to 20, so I think doing it across the board would be advisable in light of the way things are going. And to maintain consistency amongst groups. We're kind of lagging a little bit sort of behind schedule. Any other burning comments?
Yeah, thank you. Yeah, I've overstayed my welcome on the podium. I just want to...
Oh, I didn't realize you...
What's that, sorry? Oh, sorry.
I mean, we can extend things a bit further.
I've overstayed my welcome on the podium, and so I'm not going to talk about it. But one of the other things is Lisa was mentioning is that we do have to start thinking about the next steps, and one of the next steps is going to be looking at auditing, which is not anything we have to discuss in detail today, but I just want to present it as one of the ideas of things that we're going to be doing moving forward. And our contact person, again, if you have any questions about the PAH tool, exploratory questions or more detailed questions, the best first contact is Lena, who is available 24 hours a day, 7 days a week at the following phone number. So. Okay, thank you.